Probably all like to start on time when you do your work, and so we'll try and kind of get us rolling here and make things happen. Welcome. This is our 24th conference that we've done in the fall, or as it happens, early winter, focused on psychotherapy and mental health. We do a lot of different kinds of things. And so if you haven't been to one of the HSI or Canvas Health programs in the past, we're so glad that you're here. Lots of you are staff. Some of you are former staff who still love us and come back, so that's all cool too. We have three different presenters today, and they're all experts, and they have slightly different views. We're going to talk about them in a moment. But to begin with, let me just say that this conference began about December of last year or so, and one of my initial consultants about this concept was Dr. Joe Gronengay. I don't know if Joe is here today, but thank you to Joe. And then from Joe, I talked to a lot of other people about this sort of general concept. Tom Rutter, our COO from Canvas Health, was influential. And then Sherry Vries, Kathy Makowitz were big sort of guides, sort of spirit guides in how to put this together and plug the different pieces. Canvas Health's development department made this so much easier. And then we have some sponsors. The Connect Children's Mental Health Partnership, Washington County Department of Public Health and Environment. And then we had funding from Hazelden Betty Ford through a grant from Fred C. and Catherine B. Anderson. And let's see, I think there's somebody else in this little thing I want to make sure I reference too. And the Washington County Local Public Health Grant. So all those players came together, and then Dr. Berg, of course, was one of my consultants. And so as I said, Dianne, here's a thing. What do you think about this? And she said, well, you could do this or that. And then I said, would you be interested? And she said, I thought you'd never ask. So I got around to it. I'm kind of slow sometimes in figuring things out. But so, all right. Two purposes for this image. One is to warm your hearts, get a little oxytocin flowing maybe or whatever, and sort of help you feel one with your fellow audience members and our speakers and the whole day, the whole event. And the other one is to remind you, as I have to remind myself about now, deal with the technology so it doesn't make things uncomfortable for the rest of us. Okay. Bathrooms are all over the place around here. We will have a couple of breaks, one at 10:30 this morning, and then we'll announce them a little bit later on. At the end of the day, we'll have your CEU documents. If you're on the web, we will have a special CEU mailing to you. So welcome to our webinar audience. We're glad that you're there too. And you will be able to send us questions. One of our staff, Julia, will be monitoring your questions and then bringing them forward to us so that our speakers can respond to your questions and ideas, as we will for the people here. Lunch is one of the things that draw people to this venue, and so it's not bad. You know, you'll probably find something that you like. It's also pretty easy to find dietary special, you know, accommodations, I think, here. So that's one of the reasons we like this place too. Okay. So a little bit of warm up to the general flow of things. So diversity is something we pay a lot of attention to these days, at least in our business. Maybe there's some sort of opposite business where there's an anti-diversity. We could imagine an anti-diversity business. And so, you know, just know that they're out there. But for those of us who are kind of in the interested in diversity business, you know, we kind of think about, how does this work? How does it happen that someone is on the outside of any given little club, and how can we make things work better for them? So that's part of what we're trying to think about and do today, because really, it's a lot of work. It's more work than people realize to understand and empathize and say, I kind of get that there's somebody who doesn't have the privilege that I do. So we really want to make sure that we embrace that concept. And then, waking. So what does this mean? This is a term that you hear in the culture right now, various ways. Some of it has to do with Black Lives Matter. They have their own special sort of spin on it. But waking is just one of those things that I think people do, culture does, society does. We try to become more aware than we were, and this is sort of like an evolving process for us. All of a sudden, things become visible, like we have this realization moment. And so that, I think, is what drew me and drew us to this conference, is the idea that we're trying to wake up to the possibility that there are non-hetero people who maybe we never thought about before. We just sort of drove over them with our Hummers. And so let's not do that anymore. Let's figure out if there's a way to make this work for them too. So we'll try to get smarter, get wiser, get more inclusive. All right, let me introduce to you Dr. Dianne Berg. Dianne is somebody I have known for a number of years. She was actually a doctoral intern at Canvas Health, sort of in my earlier days at Canvas Health, and from there went to the University of Minnesota, I think pretty directly, right? And became a part of what's called the Program in Human Sexuality. And then there's some other sort of subunits of that PHS that Dianne has been an influential part of. She's a graduate, doctoral graduate, Ph.D. graduate of the University of Illinois at Champaign. And so is Dr. Feldman, who you'll hear from this afternoon, it turns out. Dianne's interests are in transgender, gender-creative children, compulsive sexual behavior. The PHS does a lot of assessment of people who have a lot of different sort of experiences of sexuality and sexual behavior, and they, I think, are sensitive and inclusive and really try to appreciate it from a non-legalistic, very humane point of view. So Dianne's done a lot of publishing. She's done a lot of presenting over the national and international scene. And every year she comes back to Canvas Health and she gives our doctoral psychology internship the privilege of a couple of hours of training on sexuality and interviewing, sexual history interviewing. And she gets the highest marks every year. She will give you the same quality. So let's welcome Dr. Dianne Berg. Okay. Let's see, I thought I did that. Alt-Tab, Nick? Alt-Tab.
Here we are.
Yeah.
With all our technological wizardry.
There it is. This is you. Do the slideshow. Oh, that one. Here. It'll come.
Yep, you got it.
Okay. But that's not the view.
No, I'm good. Yep. All right. Thanks, Jim. By doing that introduction, I can skip a number of slides because you said a good thing about the program in human sexuality, so I don't have to do those slides. So we'll be able to move into more of the gist of the conversation today. So, like Jim said, my name is Dianne, and I use she and her pronouns, and I have my pronoun button on. If anybody would like a pronoun button, I have some extras up here that you can come up and get during the break. And right from the get-go, I want to acknowledge that as a white, middle-class, 50-something, highly educated, cisgender, mental health provider, and psychologist. I come to this gender-related work from those experiences and all of the bias that's inherent in that history. And because of that, I have some insights, and I also have a lot of blind spots. I have a lot of ways that I need to keep waking up to. And today, my task is to talk to you about waking up to this thing that we call gender diversity. And for the most part, that means focusing on the T within the LGBTQA acronym. And a little bit, I'm going to focus a little bit on the Q, depending on what's meant by the Q. There's different meanings that the Q has, depending on who you talk to. Does the Q stand for queer? Does it stand for questioning? And if it's questioning, is it questioning gender or sexual orientation? So the Q can get kind of confusing. I wish we had a Q word that was confusing. I guess we could. We could call it confusing. So I'm going to be focusing on the T, and this depiction is really important because even though the military has now actually moved beyond don't ask, don't tell policy for trans service members, the sentiment of the cartoon is still accurate. While the LGBT has become a catchphrase, acronym, the reality is that in many ways the T has been left behind. While the acronym was meant to be inclusive, it is now used with little thought about whether what is actually being said is as applicable to the T as it is to the LGB. So this morning is purposefully focused on the T. Whoops, wrong way. Nope, it wasn't the wrong way. I tricked myself. I also want to acknowledge my colleague, Katie Spencer. Does anyone here have a work spouse? Somebody that you work with, that you're really close to, that you feel you do really good work together with? Well, Katie is my work spouse, and I'm really blessed to have that collegial relationship. We are the co-coordinators of the Transgender Health Services program at the Center for Sexual Health, and her emphasis is on adults, and my emphasis is on children and adolescents. So when I say we in this presentation, I'm usually referring to Katie and I, and the program that we're trying to make better at the Center for Sexual Health. Now, Jim talked a little bit about the Center for Sexual Health. Just want you to know it's the clinical arm of the program in human sexuality. The program in human sexuality is much bigger. It does research, education, and advocacy, but the Center for Sexual Health is the clinical aspect of that. And we provide all of these services through a multidisciplinary approach, including all of our appointments with adults, adolescents, and children. We have over 1,800 patient visits a month. And as the focus today is on our transgender health services, just to talk a little bit about that, our adult transgender health services has been around for over 30 years and was one of the first gender clinics in the US. Back then, the program in human sexuality was doing this work before it got popular. And I think that's really important because we're going to keep doing this work after it isn't popular anymore. Because right now, it's really popular. Well, I've been seeing children and adolescents since I started working at the program in 1999. I officially started the Child and Adolescent Services in 2009. And it became really, really clear really fast that we didn't have the capacity to see the full range of sexual issues that children and adolescents needed support with. And so we really tunneled into just the gender stuff. At some point, my hope is to expand that, but just meeting the capacity for gender has been overwhelming. So while the broader mission of the program in human sexuality is to revolutionize the sexual climate, mine and Katie's mission is to revolutionize the gender climate. So part of what I want to do for you today is be really upfront that we're approaching our work, Katie and I, from a perspective that we may figure out isn't right. There's very little research in this area, and so we're kind of doing our best to figure out, based on what we know, kind of what's the best way to approach this. And over the last 2 to 3 years, we've kind of come up with this thing that we call the gender affirmative lifespan approach. And our goal is to eventually be able to do research to see whether or not these ideas are actually empirically sound. But right now, that's kind of not where we're at, and that's really not where the field's at. And so just know that this is our perspective, and whether it turns out to be kind of correct, we'll see. Now, this next part is very important. We talked a lot about what we wanted to name it. It's actually had lots of different names. And we came up with gender affirmative rather than transgender affirmative lifespan approach because while our thinking about this approach has really evolved from our work with trans and gender creative children and adolescents and adults, we realized that all of the core kind of things that we're talking about are really important for everyone. Everyone has a gender, and everyone has to deal with the fact that they have a gender and the gender norms that are placed on us because of that in our society. And so just like sexism and racism and homophobia are everyone's issues, so is gender. And so our goal is to revolutionize the gender climate for both cisgender and trans-identified people. We're going to do some introductory work, and then we're going to move into some of the important themes and controversies that exist right now in transgender healthcare for children, adolescents, and adults. Oh, and I should let you know, we have to get those slides into the people who make them ahead of time, right? And then presenters tinker and do little tidbits and mess around with things. And so there's going to be some slight differences possibly in your handouts than from what's up here. But for the most part, it follows it pretty clearly. Then we're going to move into themes and controversies. And hopefully by the end of today, we'll have time to talk about the gender affirmative lifespan approach. And more importantly, we're going to make sure that we get to what we can do, what all of us can do, and what our role is in changing the gender climate. But before we do that, we need to address the elephant in the room. We have to talk about what a Trump administration could mean for transgender healthcare. Prior to the change in the national political landscape brought on by the recent presidential election, steady gains were being made, putting TG healthcare at a really important crossroads. With the political shift, it is vital to be aware that those crossroads now look different. And for many, there's a fear that they will dead end as Trump takes office. In the last 5 to 10 years, demand for services has grown exponentially. Every gender-related clinic in the Twin Cities has been bursting, and that trend is reflected both nationally and internationally, with a particular emphasis on children and adolescents. Campus Health choosing to have an event like this is so important because there is a lack of gender-competent providers. And so the first step towards competency is waking up. Now, I'm not sure what's going to happen to this demand as the Trump administration takes office. Prior to November 8th, I was going on my merry way and predicting that demand for services was only going to increase as trans-related issues continue to be at the forefront of the popular media in what has shifted to be a much more positive way. And that was allowing more people to feel comfortable seeking services to help them express their authentic selves. Now, what's going to happen? It could be that the demand for services will slow down due to increases in stigma and discrimination. That's already happening because that will make people kind of have fear about moving forward. We've already had 4 patients call and cancel their appointments for their children due to their belief that, or 4 parents call, due to their belief that it was no longer safe for their child to openly explore their gender exploration. It could be that the demand will stay the same, but the reasons why people seek services will change. With an increase in people seeking services in order to offset discrimination, stigma, and the increased sense of alienation that they feel. All of which, we know, leads to increased mental health concerns. And it could be that services will increase for those same reasons. We don't know, but it is a big shift. Through a combination of policies, lawsuits, and public statements, the Obama administration has consistently been changing the landscape for LGBT people. Just to give you one example specific to the T, On May 13th, signed onto by both the Department of Justice and the Department of Education, President Obama issued a directive telling every school district in the country to allow transgender students to use the bathroom that matched their gender identity. As of early summer, 11 states are suing the Obama administration over this directive. At the heart of this are interpretations around civil rights, whether our nation's sex discrimination laws apply in matters of gender identity, and that case will now be going to the Supreme Court. So we're at a crossroads in terms of the legal stuff around transgender rights. We're also at a crossroads in terms of best practices, in that guidelines and standards of care are being developed by many different disciplines, including psychology, psychiatry, endocrinology, as well as governing agencies like the Substance Abuse and Mental Health Services Administration within the Department of Health and Human Services. So when you start thinking about who we're going to have in the cabinet as the head of Department of Health and Human Services, what is that going to mean? And as the field of trans healthcare grows, there's growing pains. Currently, there's a substantial movement of trans health providers and advocacy groups asserting that the shifts that have been very beneficial for adult transgender healthcare should apply to adolescents and children. One important example of that is the debate that adolescents should be supported as autonomous decision makers, meaning that they should have the final say because it's what they want and need over having irreversible medical interventions. Thus, the field is really at a crossroads of figuring out how competent and affirming care can also be done well within a developmental context. So these are some of the questions that are being asked as we look forward to the Trump administration. These were gathered from various websites, including those belonging to the ACLU, the Human Rights Campaign, Lambda Legal, the Washington Post, the New York Times, and the Transgender Legal Defense and Education Fund. But the person I found to be the most concise about the issue was Samantha Allen, who is a Ph.D. from Women's Gender and Sexuality Studies at Emory University, and who also did the 2013 John Money Fellow at the Kinsey Institute. And I want you to read some of what she wrote. I wish that a Donald Trump presidency were more of a surprise, but transgender Americans have always known how powerful hate can be. Under President Obama, transgender people have benefited from piecemeal progress in public policy, largely held up by executive action and court decisions. Whether they were combating housing discrimination or protecting transgender students or fighting healthcare exclusions, various federal departments advanced transgender equality in quiet but significant ways. This will likely change. For starters, Mike Pence has already suggested Donald Trump will roll back the Obama administration's guidance to school districts regarding accommodations for transgender students. If that guidance gets rescinded, the issue will be referred back to the local level, which means transgender students in hostile school districts could face even more discrimination than they already do. And they might not stop at undoing Obama's administrative progress on transgender rights. They could set back the clock even further. And they could do that through the makeup of the Supreme Court. And they could do that through congressional issues. And so she writes, and they could do that through the Affordable Care Act. So she writes, for transgender people, none of these problems are brand new. They've been facing them and surviving them for decades with no expectation that they would end in our lifetime. But many of us were at least hoping that our situation would marginally improve under our next president. So these aren't fun things to discuss, right? As I prepared this part of the presentation on Wednesday, I thought, do I really want to go here? Do I really want to do this? And yet, do I want to do this like right off the bat? You know, it's like right out of the gate. And I thought, yeah, we have to do this. Because waking up requires us to understand as best we can the positions that our clients are in. And I can tell you that post-November 8th, in my therapy sessions with trans-identified clients, adults, adolescents, and children, children were coming in having age-appropriate comments about the election. Nearly all of these people have come in with some need to talk about their thoughts, feelings, reactions, fears, and sense of hopelessness related to many of these questions. So it's even more important that we get to work. And we have to get to work by having our own little revolution. So to set the stage, we need to start with a common gender vocabulary. Remember that to provide gender competent care means to provide developmentally appropriate care. So let's do some Gender 101 with the emphasis on children. How many people have seen the genderbread person? Okay, a few. There's a little bit of controversy about using this image, and that's because, I'm not sure I'll have it exactly right, but this image was originally, people believe, created by a trans person, and then was co-opted by non-trans kind of culture. And so I struggle to use it because of that, but I also think it is like the best image for children because they relate to it really well. In a little bit, we'll see another image that we could use. So it's really important to understand the genderbread's representation of the different aspects of sexual identity and how those aspects are distinct but also interactive. So one of the aspects of sexual identity is biological sex. And biological sex is pretty simple for the most part. It's the question that when a baby is born, we ask. What do we ask when a baby's born? Is it a boy or a girl? It's fascinating, right? We don't ask, is it healthy? We ask, is it a boy or a girl? Whether the baby is a boy or a girl is, in this context, is based on what biological indicators, sex chromosomes, internal reproductive organs, external genitalia, so private parts. Does this baby have a vagina and clitoris, or do they have a penis and testicles? And the indicator that's usually used is just the private parts, because that's what you see. Okay? And you also have to have like a professional do that, because when my baby was born, the doctor asked my wife to say whether it was a boy or a girl, and she got it wrong because of all the swelling and everything. So it was like, oh, it's a boy. No, actually, the doctor said, no, actually, it's a girl. So for the most part, you may have all heard the term assigned gender or assigned sex versus affirmed gender. Basically, based on private parts, before it's really possible to know a child's gender, babies are given an assigned gender, either at birth or in the presence of a disorder of sex development shortly after birth. And then based on that assignment, cultural norms around gender then begin to be attributed to that baby. At some point, the baby, as the child grows, will begin to tell us whether the gender that got assigned is how they actually think and feel. Now, language is really, really powerful. And many of the children that I work with and adolescents come in with and adults actually come in with the belief that they are, quote, not a real boy or girl. In working with children and their parents, trying to change my language to reference specific body parts rather than just the words girl and boy, or even girl parts and boy parts, instead just using specific words for the parts and introducing basic concepts like, oh yeah, I've met other kids who right now identify as girls with penises and boys with vulvas. Now note that I also try to use language that's very time sensitive. So I said right now, and we'll talk about why that time sensitive language is important, and it's important to be aware of it. So while we often think that there are only two options, male or female, biological sex or natal sex is actually not that simple. Sometimes a baby is born with sex chromosomes, external genitalia, or an internal reproductive system that is not considered standard for either male or female. And these types of individuals used to be called hermaphrodite, then the term intersex, and if possible, now the most appropriate is to use the term describing the actual condition that the child has, like congenital adrenal hyperplasia or androgen insensitivity syndrome. Now, children with disorders of sex development should not be confused with gender creative children. They can both co-occur, but they are two very different things. I only bring this up in this presentation because I want you all to have the awareness that even the biological sex is on a continuum, and it is not as simple as it seems. 1 in 2,000 births, there's ambiguity. So regardless of one's body parts, gender identity is how a person thinks and feels about themselves in their head and their heart. It's kind of that basic conviction of who they are in terms of this thing that we call gender. Now, everyone has a gender identity that's congruent or not congruent with their assigned sex. Research based from a cisgender perspective says that gender identity development becomes aware around 3 to 4 years of age, although because gender identity and gender expression are really abstract concepts, it's really difficult to separate those out at that age. It's not uncommon for some people to be aware that their gender identity does not match their assigned sex very early in childhood. And it's also not uncommon for people to become more aware of their gender identity in puberty with the onset of secondary sex characteristics. So there's a developmental process that can happen. Now, how many of you have heard of the word cisgender? Oh, more people have heard of the word cisgender than seen the genderbread person. All right, okay. So that's great. I've already used the word a number of times in the presentation. Cisgender is a word for someone who has the conviction that their gender identity is congruent with the one that they were assigned at birth. And what's important here is that cisgender people have privilege. Most of the parents of the children that I work with are cisgender. And one of the big learning curves that they face is that until they have a child who's gender creative, most haven't had to even think about the concept of gender, or that they even have a gender, much less what it means to grow up with there being some sort of incongruence and trying to live in a society where that incongruence is not honored. So part of waking up to gender diversity with our parents and with all of us is recognizing how much we have actually not been aware. So let's see what some of this says. Did you know, I know that the writing's really little, did you know that cisgender people can often be upset if you get their pronouns wrong? If you aren't sure, remember that it's okay to ask. Can you imagine if over and over and over in all your conversations with people, people mispronounce you constantly? Don't ask cisgender people about their genitals or if they've had surgery. Well, some cis people are happy to talk about their bodies. Most will consider it rude. And yet that's the thing that everybody keys in on. Oh, had they had the surgery? I wonder what their private parts look like. We don't walk around doing that with cisgender people. And the last one, keep an open mind. Although the news media often tends to reinforce certain stereotypes, cisgendered people come in all shapes and sizes. So the point of this is to try to get me, as a cisgendered person, to realize how unaware I actually am of the experience of trans-identified people. So transgender is an umbrella term that's used to refer to individuals who cross or transcend culturally defined categories of gender. That may mean that they transition from one gender to another gender, and or people who defy social expectations of how they should look, act, or identify based on their assigned sex. Unfortunately, and this is where some of the developmental stuff starts to come in, I think that the term is now also being used with children. So you hear a lot now about transgender children. The use of transgender children, or the use of the term for children, seems to have first happened with Brill and Pepper's 2008 book, which was all these books are great books, okay? Since then, using the word transgender in some way to describe gender-creative children has become very popular terminology in both the clinical, research, and popular media. Now, for a variety of developmental reasons, I think it's very problematic to confuse how we think about and therefore respond to adults versus adolescents versus children when we're thinking about these gender-related topics. I think that by using the term transgender for children, and this is just my kind of state of things, a lot of people are doing it. I think that by using the term transgender for children rather than something like gender creative, we really promote the lack of developmental distinctions that are very important to keep in mind. Because our mindset of what we think about transgender is based on, usually, is kind of what we know about adults. But we shouldn't be, I think, applying all of that to the to gender creative children who are 6, 7, 5, 8 years old. Now, you have to understand the concepts of the gender binary versus the gender continuum or spectrum. The gender binary reinforces that there are only 2 legitimate options for gender expression and identity, and that there are rules about how you express those 2 options. An example of how ingrained the gender binary is in all of us is that we all know, whether we agree with it or not, what color baby clothes infants are supposed to be dressed in. What are they? We all know it, right? We might not agree with it, but we all know it. Our treatment approach at the Center for Sexual Health asserts, and in a lot of other places now, asserts that the gender binary isn't that good for anyone, given how limited those gender binary boxes are. Therefore, we support the idea of the gender continuum or spectrum, that there's a continuum that runs from the pinkest pinks to the bluest blues, from the girliest girls to the kind of, in our cultural standard, the boyish boys, and that there's somewhere that you can land that's in between there. And that landing anywhere on that continuum, the ends, or anywhere in the middle, is perfectly fine. That's what's great about continuums, is they're really inclusive. Terms like gender creative or gender expansive in terms of children are now being used as a more positive term for what we used to call gender non-conforming children. Note that Dianne Arensaf, who wrote the book Gender Born, Gender Made, Raising Healthy Gender Non-Conforming Children, she actually differentiates between gender creative children and transgender children. So she's one of the people that does kind of support the use of that term. And she uses gender creative children as an umbrella term for children who do not follow, in all sorts of ways, the prescribed gender norms or rules of their culture. Now, while I have not had a child ever come into my office and say, "Hi, Dr. Dianne," or Dianne, or whatever they want to call me, "I'm a gender hybrid. And actually, I'm a gender Prius." Never had a kid say that. What they say is they say, "I'm a girly boy." Some say I'm a pink boy. Some say I'm a tomboy. They use those terms. But I think her point is good. And her point is that it is important to identify each child's unique gender self. And as we listen to children and help them be more authentic people, it can all be about differences in their gender identity and expression. If we're not able to make these distinctions, and instead we lump all of the gender creative children together, we may simply create new boxes and unwittingly support or promote unhealthy outcomes for everyone who deserves to be recognized as his or her unique gender self. And please email me or call me the first time that a kid comes in and says, I'm a gender smoothie, because I want to know about it. So the next kind of aspect of sexual identity is this gender role or expression. And this is just basically how one presents in the world in terms of taking on culturally defined traditional masculine or feminine roles. And culturally defined is really important because in the 1920s, every woman that's sitting in this room would be very much outside of what you are supposed to be wearing right now, right? Probably the guys too. This is about how masculine, feminine, or somewhere in between one presents through things like clothing choices, hair choices, body language, and personality. So in the 25 years that I've been in the mental health field with working with children, I have really seen a decrease in the level of intensity of what we used to call sexual stereotypes. In that it's sometimes much harder for children to think about the world this way, and I think that's good because we have less cultural indoctrination around that. 20 years ago, there were very few books, if any, that had gender creative children in them, like my friend here, Roland Humphrey. 20 years ago, a child, say age 9, would be able to give the stereotypic responses quite readily and easily, whereas now, they can still give. It's pretty typical for a child to both show their knowledge of the stereotypes, but then freely give examples that contradict the stereotypes around gender expression or indicate that they don't think that the stereotypes should exist. So examples of that is, well, what about those guys with ponytails, Dr. Berg? What about them? Girls in my class can run super fast. I always want them on my football team. So when I show images that are gender creative to kids, it's very interesting to see how they will react. Here's a question for you all. Which of these two pictures do you think tends to get more comments? And what types of reactions, remember these are children reacting to these, what types of reactions do you think are made? Just kind of think to yourself. I'm seeing a range of children. I'm seeing more and more children who grow up in environments that are intentionally not reinforcing the gender binary, who, if they're still fairly young, 5 or 6, they're much less aware of the rules that are imposed by the gender binary and respond to these pictures kind of with a no biggie. I'm also seeing those children that know the rules and think that they're silly, and they'll respond with things like, hey, that's pretty cool, that's cool with me. And there are those children who have gotten very clear messages about how important it is to follow the rules of the gender binary. And so they say things like, oh, my dad would not like that. But what's most interesting is that I'm now seeing children who have done an early social transition responding to these types of images with statements like, what's the matter with him? Or why would she want to do that? And these negative reactions from gender creative children about other gender creative children really got me thinking about what we need to be doing. And it got me thinking about this idea of gender literacy, which we'll talk about when we get to the model. So just kind of store that away. Sexual orientation is the last aspect of sexual identity. And it's often confused with gender identity, although I think much less so. I think if you gave a quiz, people would not confuse these anymore. But if you just watch in popular culture, it gets confused all the time still. So given that we're talking about prepubescent children right now, sexual orientation is much less relevant. Developmentally, it usually gets on the radar around late childhood and becomes clearer as one moves through adolescence. But basically, sexual orientation is who one is attracted to. So basically, The image of the gendered-bred person becomes much more complex when we leave behind the binary view and we move towards an idea of spectrums. Now let's just get into some of the important themes that are happening around children right now. We have no time today to get into this discussion of whether a diagnostic category should exist for gender dysphoria or gender creative children, but I want you to know that there's a huge controversy about this. And the controversy is whether this diagnosis should exist for anyone, much less children. What I want to get into more is just letting you know, and the reason why this is important is because all of the research that we have right now is based on DSM-4. DSM-4 diagnostic criteria did not adequately differentiate between children who were gender dysphoric and children who were non-conforming or creative. In DSM-4, the diagnosis of gender identity disorder, which is what it was called, now it's called gender dysphoria, could be met through gender nonconforming behavior without any indication of gender dysphoria. So in DSM-5, they've changed the name to gender dysphoria, which is more in line with affirmative approaches as it shifts the focus to the distress that's felt from the incongruence rather than on the identity as the problem. And they also changed the criteria so that a child can no longer meet the diagnosis through only gender nonconforming behavior. Now you need some indication of gender dysphoria because the child has to meet criteria 1. And the other thing that's interesting is the people who came up with the diagnostic criteria is that they kind of are starting to understand this binary concept because they said, or some alternative gender different from one's assigned gender. So they're not always saying opposite. They're saying it's much, much broader. But most important in terms of the diagnostic considerations is what does meeting the diagnostic criteria in childhood tell us about future gender dysphoria as the child grows up. And what we know from the research with adolescents is that it's pretty clear that if there's gender dysphoria when you're in adolescence, it's pretty clear that it's going to persist. You're going to continue to have gender dysphoria. But the research actually suggests, the opposite for children. And this is extremely controversial. It's clear that the research shows, and this is a body of research at this point. There's lots of studies that have now been done. And the research shows that for the majority of children, 85% diagnosed with, now here's the trick though, with DSM-4 criteria, that the gender dysphoria did not persist. Instead, kids that were diagnosed with DSM-4 criteria ended up to be cisgendered, most of them cisgendered, but more likely to be gay or lesbian. But here's the catch. Even though the diagnostic criteria are now moving in a more clear direction, all of the current research knowledge is based on this diagnostic criteria that couldn't differentiate who were the real gender dysphoric children and who were the, for lack of a better term, kind of the tomboys or the, in a non-pejorative way, kind of the sissy boys. Does that make sense? So in other words, until the research catches up, using DSM-5 criteria, which hopefully will kind of narrow the focus, we will not have the evidence-based information that would be good to know. There's no scientific evidence at this point that helps us discern who the children are who will eventually identify as trans in adolescence and who the children are who will not. But there are people who think that they can. And maybe they can. I don't have a magic ball, so I know that as a gender specialist, I'm not going to say to a 6-year-old's parents, yes, for sure, your kid's going to end up to be trans. Because there's no research evidence to support that yet. but I want you to know that this is hugely controversial, and it makes a big difference in how you go about doing treatment and what you focus on. Does that kind of make sense to people? I'm going to take one question because this could turn into, and I know that. So Mark, go, and because it's you, Mark, I'm gonna do it because you were my supervisor, so I have to. Mm-hmm. Right. Mm-hmm. Mm-hmm. Another kind of category. Yeah. And I'm sure there is, and people divide this in all sorts of ways. I'm just dividing it in these 4 ways. I think you ask a really important question, but you ask it about adults, which is a really important thing to recognize, right? I specifically said we are now talking about children, and everybody's doing this in their heads because this is the point of reference that we have. And what we automatically do is we start thinking about our adults, and then we start kind of extrapolating. And so I think it's really important if we're going to be developmentally appropriate to kind of keep the focus where it is. We are going to talk about adults after the break, and so we can do that. But I think, just to give you a brief answer, I think that that's very true. I think that might be true because of the socialization in adults, that they have been socialized in a very different culture than the little kids that we're seeing now. And it could be that the little kids that we're seeing now will not have that much of an incongruence. But the other thing is that that's all predicated on the binary. The fact that diesel trucks are supposed to be male and hair cutting is supposed to be female, we're right back to the binary. And so if we kind of got rid of the binary, we would get rid of even caring about this stuff. Okay? So what does it mean if a child meets the diagnostic criteria? What does it tell us about the future gender dysphoria? All of the following are possible as the child moves into and through adolescence. They may identify as cisgender and heterosexual. They may identify as cisgender and gay, lesbian, or bisexual. They may always be a masculine girl or by cultural standards, or a feminine boy, but never desire to live as an alternative gender. They may identify as genderqueer or perceive gender as fluid. They may identify as trans and may transition socially, but not medically. They may strongly and persistently identify as trans and pursue, because of that strong identification, both social and medical transition. So all of these are possible when you have a 6, 7, 8, 9-year-old. 10, 11, right? What's fascinating to me right now, and it's a good thing that we have positive messages about transgender stuff right now in the popular media, but what's interesting to me is that if a kid comes into your office or if a kid has gender creativity, the popular narrative is that they are going to do the last one. And I think we need to shift that at least until we have research that supports that that's actually the case. Does that kind of make sense to people? So let's back up just a little bit. Do people know what I mean by early social transition? Some nods, not as many as no cisgender. Okay, all right. So early social transition is when a young child, pre-pubertal, okay, so young child, would involve things like using a different name, using a different set of pronouns, and or living in the role of the preferred gender through their clothing choices, their hairstyle. And you can do that in a partial way or in a complete way. So, for instance, a child with penis and testicles could take a dance class in the female role, but still go to school in the male role. And that would be a partial social transition. They're kind of testing out what does it feel like to kind of be in a gender expression differently in different contexts. Or you could do that kind of completely. So some children do that, and what's fascinating about this is some children do this on their own. So their parents will come and pick them up from a birthday party, and they'll figure out that everybody is calling the kid with the other pronouns, and they've even, like, some of them are even calling them with a different name. So children are kind of doing this in different contexts, kind of on their own, or with guidance from a parent, or with guidance from a practitioner. Now, there's one more study that I want to discuss before we get to the meat of this, and that is this Olson study. You have to understand that historically, research on children who met the DSM-4 criteria, because that's all the research we have, were consistently found remarkably high rates of anxiety and depression. Okay, that's like the body of research is clear about that. Because of the changing landscape around early social transition, it's now possible to examine the mental health of children who have been supported in early social transition. There's enough kids now. So Christina Olson, a psychologist out of the University of Washington in Seattle, did just that as part of her ongoing Trans Youth Project, which is a longitudinal study of American Canadian, she uses the term transgender children, development. The purpose was to examine the mental health of children who were supported in an early social transition as compared to both a matched control group and a sibling comparison group. She recruited these families and had the parents complete anxiety and depression measures. And what she found is, compared to the matched controls and sibling groups, socially transitioned, quote, transgender children had developmentally normal levels of depression and only minimal elevations in anxiety. And what this begins to suggest is that there's nothing inherently psychopathologizing about having gender dysphoria or being a gender creative kid. And that's a pretty landmark kind of study to start doing. And of course, she'll do follow-ups and all of that. Because there's been this idea that there's something inherently wrong with people's mental health if they have gender dysphoria, rather than what's probably more true, except for, of course, everybody has some mental health. You know, we have a swath of the population that's going to have mental health issues no matter what. But the increased incident is probably much more likely to stigma and discrimination and lack of access to supportive kinds of environments. So her conclusion is that these data are suggestive that social transitions are associated with positive mental health outcomes for transgender children. So one of the biggest debates going on in the field right now is whether it's a good idea to have children do an early social transition. And parents are coming in for intakes with their kids already socially transitioned, or socially transitioning their kids between the first and second appointment. I mean, it's happening. And while there's little research, the research really promotes caution around this. There's a wide range of clinical opinion about this. So the field is really caught up in a hugely swinging pendulum. 10 years ago, early social transition of gender-creative children was seen as over-the-top progressive. What is now being called reparative therapy, where the goal was to kind of have the child accept and be happy with their assigned sex or gender, was not at all uncommon 10 years ago. Now this type of approach is seen as unethical, and all the standards of care and practice guidelines condemn it. So the pendulum has done what pendulums do early in their arc. It's swung far to the other side towards supporting early social transition, and this is the popular narrative in the popular media and on listservs and on parent support groups about how you can be most affirming to your gender creative child. What I want to say is we need more research, and that's going to take time. And in the meantime, my concern is that parents are being unduly influenced by the popular narrative And that this combined with the pressure of the binary and with the ease with which prepubertal children can actually do an early social transition, it's actually really easy to do it. That early social transition is becoming a more attractive option than holding and tolerating the ambiguity that comes with being on that spectrum somewhere. It's way easier because we live in a binary to just jump the box. What I think we need to be doing is creating spaces, and jumping the box might be the best thing, we don't know. And we support people who want to jump the box, but we do it in a very kind of cautious way. So what I want to do is create space that people don't have to jump boxes unless that's really going to be authentically kind of what fits for them. At this point, though, the horse is out of the barn, it's happening, and so the question is no longer should early social transition happen or not. The question that we need to be asking is, how can an early social transition be done in a way that promotes the most optimal mental health for a given child? And I'm going to just kind of cut to the chase. I think we have to do this in a way, if we're going to do early social transitions, we have to do it in a way that's very exploratory. So what's ending up happening, because we've got this top-down thinking about transgender adolescence, and we're applying it to children, is parents come into your office, this kid has done an early social transition, and that's going great. And the things that parents are saying to 7- and 8-year-olds, not all of them, but some of them, are saying, well, and honey, when you go on puberty blockers, and when you go on hormones, and they're not saying that's going to happen right now. They're saying in the future that's going to happen. And so there's no way for that kid to have the room to at some point say, oh, I'm not really sure. I'm not really sure what's going on, right? Because we're already kind of tracking them into this narrative that fits very well and is the standard of care for adolescents, but might not be what we need to be doing with children. Does that make sense? So I'm always talking to parents about how do we change our language? How do we say, well, we're going to see. You're in 3rd grade. Who knows? You didn't like broccoli last year, and now you really like peas. So we're going to kind of see kind of what happens in 4th grade. So keeping things very time-sensitive and very context-specific, I think, is a very important point, so that children know that they have the option to change and be fluid if that's what's going to fit best for them. And that's actually really tricky, because when you do an early social transition, while it's easy to do in some respects, a lot goes into it. Some people will move school districts to have this happen. And so I think it's really hard for children when they know that these huge changes have happened to be supportive of them, and it is for supportive reasons, to kind of say, oh, well, never mind, or I'm not really sure, I think is a really hard thing for children, which is why we really need to keep it this is fluid, and we don't know what's going to happen, because that leaves the door open for all possible trajectories. Does that kind of make sense to people? The other thing that the last bullet point is I think we need to think really deeply about doing it a social transition in a stealth versus a coming out sort of way. So what is the message that we give children when we say, hey, you're free to be whoever you are, but let's just not tell anyone about it? Note that research with adults has suggested that concealing what is considered to be a stigmatized identity can lead to psychological distress. So how we do an early social transition is probably way more important than whether we do it or not, as long as we keep the fluidity in there. Okay, we're going to do two minutes of this. You had one. Yeah, so the question is about precocious puberty. So that's a whole different kind of ball of wax, right? Kids who are cis and gender non-creative and gender, all of them could go into precocious puberty for any, well, not for any reason, it's a medical issue, but, right? So in terms of precocious puberty, I have no concerns about using some sort of suppression to, because that's the medical standard of care for that particular thing. But that's very different than gender dysphoria. Kids who have gender dysphoria don't usually have precocious puberty. Is that a question in your mind? What I was saying is that any child could have any medical condition, and precocious puberty is a medical condition, right? Gender dysphoric children have no more likelihood of having precocious puberty than non-gender dysphoric children. I think we would treat it just like we would treat any kid that has precocious puberty. The thing that's being done, though, that's important about the precocious puberty thing, and we'll talk about this when we talk about adolescence, is that that diagnosis is being used as a way to get treatment for kids who have gender dysphoria because the medication is the same, and it's a way that you can work around the insurance system. What we would say is that's not, we think it's unethical, but a lot of people do unethical things in the spirit of trying to move things forward. So there's a pro and con there. But also, I don't think it ultimately helps the movement, because what ends up happening is when those kids get beyond when they're supposed to no longer be precocious, when they actually hit puberty, they're going to need to keep taking the Lupron. And we'll talk about what all this is in a little bit. You kind of jumped ahead on me. They'll start taking that, and then they'll get flagged. So why is a 13-year-old still getting diagnosed with precocious puberty? And then it becomes a huge fight and a huge deal. So what we want to do, what we support, is just fight the fight right from the get-go. And if we have enough people doing that fight, and it is a fight with the insurance companies, if we have enough people doing that from the get-go, we'll hopefully actually change policy rather than doing these workarounds. Okay? All right. Let's see where I'm at in my thing. Oh, wow. Actually, we can do more questions. This is fascinating. This never happens to me. Okay, other questions about children. Come on. Mark, is it going to be about children, Mark? Okay, go. Yes. Mm-hmm. Very different than Brainerd. Mm-hmm. Yep. Yeah, and I think, yep. So what I have to repeat the question because of the webinar, folks. What Mark's comment was how do we factor in cultural climate around kind of early social transition, perhaps, and just supporting gender creativity, even if a child chooses not to do an early social transition. And I think that's where that concept of gender literacy that I was talking about comes in. And that concept, we'll talk more about it later, but that concept is basically teaching people and teaching little kids in an age-appropriate way to understand what are the implications, what are the broader cultural implications. How can you be gender literate? Meaning, how can you figure out what the cultural implications are for being gender creative in a given context? And how do you then make decisions about that and be proactive about it so that you are in kind of charge, you have agency? And so I think that's the discussion that we have with parents around that, which is why some of the times you kind of suggest doing a partial social transition. If you have a gender creative kid and you want them to experience kind of a supportive environment out in the world, send them to Children's Theater Company. It's very, very good at this. And that kid will get that experience without a lot of questions, and they'll just be able to kind of have that experience. And then what we do is we come in and we talk about that. What was that like? How did that feel? And I think a lot of kids, because kids have the gender binary too, right? They're being socialized too, find that it's more comfortable for them because they don't have to explain, well, actually, I'm a boy that likes girl stuff. People can just assume that they're a girl, but is that okay? Because they're actually, maybe they don't actually really feel like that. They just like girl stuff. So I think these are all the questions that we need to be aware of and be answering. Yeah. Yes. Mm. Yeah.
So can you talk a little bit about how to work within that dynamic? I want to know whether or not I'm doing it.
Yeah. So, okay, so the question was, when you have parents that have different viewpoints, different levels of support for the kid, for instance, one parent being very supportive of gender creativity and the other parent wanting to squash it. And the other thing that you said, Patricia, was, and what are the best practices? Okay, so there aren't any best practices, right? We're figuring that out as we go. We're figuring that out as we go. But I think we would know that there is a best practice generally, right? And I think what happens a lot with gender work is we get all wigged out about the gender stuff, and we forget to think about this just as how we would think about this in every family system. So if you had a family system where one parent wanted a kid to do one thing and the other parent wanted the kid to do another thing, how would you work with that? How would you deal with it? You would get the parents in and you'd be talking with them. And I think what we do is as you explain kind of the model and the continuum, and we talk about how none of this is necessarily predictive and how are you going to kind of help your kid. We talk about mental health issues and what's going to actually promote mental health and all of that. Oftentimes, they will come closer together. You're wanting to graduate towards the mean, right? And so I think one thing that comes out of Patricia's question is just we know what we're doing in general, right? If you take those general concepts, often they really apply to our work. We just have to not get freaked out about the gender stuff. That doesn't mean that after doing this training, all of you are gender specialists, right? But there isn't a need to be as, we can just think, what do I do about this, right? Does that help?
Yeah, and that's what I'm doing.
Yeah, yeah.
Do you use group approaches for the kids and or families?
Do you what?
Group.
Oh, do we do group? You're asking, do we do group? Right now, I would love to do a group with little kids and parents. We don't have the capacity to do that, so we haven't started that yet. And, pardon?
What do you mean you don't have the capacity?
We don't have the number of people. We can't even deal with the fact that we have 67 kids on our wait list right now that are having a 6-month wait to get in, much less try to start up groups. There are community groups, like Transforming Families is a great community group. My concern with peer-led parent support type groups is that they often can kind of get caught up in the pendulums. And so one of the things that often happens is whatever the popular narrative that's kind of going on will become kind of what the popular narrative is in that group, and there isn't a facilitator to kind of show the other side of that. So we don't do groups with children. I would love to do that. That's on the horizon. We do groups with adolescents. So we do tons of groups with adults. So in our adolescents they come to the group with their parent. So it's parent and adolescent group where half of the time is spent with the parent and half of the time is spent with the parents in their own group with a facilitator and the youth with their own group and a facilitator. And what's fascinating is during the together time, the youth are like, oh, can you just get out of here? Would it be okay if my parent never spoke? You know, right? Which is typical, right? That's what they should be doing. And the parents are just itching for information. They just want to know what's going on in that teen's noggin, right? And kind of what, and so, but because of the family system dynamics, we can't always get at that with that particular parent and youth because they continue to do their family system stuff in the group. So we found that we do a lot of switching it up. We'll have the parent interview a youth that's not theirs. And then the youth are just like chatty Cathy. And the parents are really engaged and they're asking questions and they're not getting blown off and they're not getting defensive. And it's like this great dialogue. And they learn all this stuff, not necessarily maybe about their kid, but they learn it from a different kid, and then they have to see whether it applies. And the kid, it's fascinating. Then you go into the kid group, and another kid will say to the other kid, you know, your mom's kind of cool. I really thought your mom was cool. She asks really good questions. And the youth is like, what are you talking about? You know, so it really gets at that family dynamic piece to do that, and we can do that because we do those groups together, and we really believe in doing that. So that's the group question. We have time for one more question. Yeah, were you? I don't know if you were. Who besides Marge was? Were you before Marge? Okay, go ahead. Yeah. So we see parents of kids who are as young as 3 or 4. And with those parents, we say, maybe we can just kind of not worry about, unless the kid's saying things like, in an age-appropriate way, I want to cut off my penis. That's very, kids of that little don't usually have body dysphoria. So if a kid is saying things that are really body dysphoric, that's usually an indication. Research will tell us this, but that's usually an indication that there is probably maybe a core gender concern going on, and that maybe they might benefit from supportive therapy. And a lot of the stuff that we do with the little kids, even 6, 7, is we're really working with the parents to provide a supportive environment. And the goal of the therapy is to increase gender literacy, to increase resiliency, to kind of provide a supportive environment. Those are really the goals of the therapy, and to help that kid explore. And so when they get to be about 6, 7, that's when cultural norms really start hitting. That's when it's no longer considered cute sometimes to be gender creative. And so we will begin to see those kids because they're having more cultural impact sometimes. They're the ones that might be getting bullied. They're the ones. 4-year-olds in daycare, it's often kind of fluid, and the daycare provider will kind of be okay with it. So it just kind of depends. But we do see people coming in as young as that, and we just kind of have to talk a lot with the parents about, would it be beneficial for your kid to come in right now? Instead, maybe we should just be talking with you all about your concerns and your fears and what issues we can help you deal with to help provide an optimal environment for your kid. All right, Marge, go ahead.
I was wondering, what kind of survival skills do help kids with regards to dealing with their hostile environment?
Yeah, so Marge asked, what are the survival skills that we do to help kids deal with a potential hostile environment? So that's a whole training in and of itself. So I probably can't get into it, but the gist of it is just having them. I think the biggest survival skill is them understanding that if they are catching crap, it is not about them. So that they're not internalizing the negative culture that's telling them you shouldn't be like you are, right? So it's that gender literacy piece again of, hey, this is kind of what's going to happen. It doesn't happen in here, and maybe it doesn't happen at home, but have you noticed that at school kids will make fun of blah 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 blah, and then having them not internalize that, but instead keep it out there so that they can say, yeah, that's going to happen, but that's not about me. And I think that is the survival skill for life. Because the biggest concern that we see in our transgender adults, so now I am going to say something about adults, isn't the gender dysphoria. That's fairly, in the grand scheme of things, that's fairly easy to kind of address. It's the years and years and years of them having to have an inauthentic self because they grew up in a culture that didn't support who they were. And so they've developed all of these survival skills that help them survive, but that maybe now aren't really helping them have intimacy with people and that are getting in the way of all sorts of things. And so while they help them survive, in adulthood, after they transition or after they realize it and are in a gender exploration process, we really start to kind of work on that deeper stuff. And I think that's the important work that children and adolescents who are growing up now might never have to do because they won't have internalized it. That's my hope. Okay, let's move on to talk about adolescence. We're going to revisit introductory concepts, but now from an adolescent perspective. We're going to talk about health disparities. We're going to talk about social transition in terms of adolescence and medical transition, including health and reproductive implications of medical interventions. So getting back to Gender 101, but this time with adolescence. So in the last hour or so, our genderbread person has moved through childhood and the tween years and is an adolescent, including, most importantly, in terms of a gender perspective, the changes that come with puberty. So can you tell that this one looks older than the other one? Maybe you just missed that. We won't go back and compare. So in terms of this, nothing's different than what we already talked about in terms of that aspect. But in terms of the gender identity aspect, notice that under this umbrella, you can see that there are lots of terms. And for those of you who work with adolescents, you know that the adolescents are coming in with a language around gender that is ever-changing and ever-broadening, and you just can't keep up. Okay? I can't keep up, right? So the terms that you might have heard or that are coming up are the terms that are on your left. You may have heard adolescents saying some of these terms. Now, we don't have time to go into what the nuances of what all these mean. What's more important is just understand that they're changing all the time, that many of the terms, this is fascinating, right? Language is powerful. So the terms that are on your right are all very binary terms. The terms that are on your left really denote the shift that's occurred around fluidity. And even older children and young adolescents are pretty savvy. And depending on how much access they have to the internet, which is a lot, and social media, which is a lot, they're finding lots of information about all of this online. And it's not uncommon for our older children to have a much more extensive vocabulary and understanding of concepts than their parents, even at age 10 and 11. The parents are always playing catch up, which is true with all parents of all adolescents, but in this gender field, because it's moving so fast, I think that parents are even further behind. So a lot of what we do with that is we just talk with both of them. Again, so that's a huge disparity, right? We've got the child that thinks that early adolescent that thinks that they know everything, and the parent who is wanting to learn. And so we talk about, yeah, you're kind of in T-ball and you're in the major leagues, and we're going to try to kind of catch you up. And you know what? Even in the major leagues, people need coaching. So maybe there's a little something that you could learn. Again, regression towards the mean. So if you want to know what all of these terms mean, or what adolescents think what they mean, you can just go to Tumblr, because adolescents are hugely using Tumblr to explore gender. And so the link to definitions for what's on Tumblr for all of those terms is right down there. Now, gender expression, again, is how one presents in the world in terms of taking on culturally defined traditional feminine or masculine roles, right? So everyone has a gender expression, which is influenced by our internal preferences and cultural expectations. I would never choose to be wearing what I am choosing to wear right now, but I have to be appropriate. I cannot come in here in my pajamas, which is what I would choose to have on right now if I could, right? There are cultural expectations. Those cultural expectations are often fluid, and gender expression is often fluid over time and context. So at a recent fancy work event that we had, one of the things that we did is we set up stations that people could come and interact with. And one of the stations is something that we're going to do a little later, where we had people take a magnet and place it on a board showing where they identified in terms of their gender identity and where they identified in terms of their gender expression. And what was fascinating about that was the questions that people asked and watching people interact with their spouses or their partners about that activity, because people would automatically ask, well, do you mean like right now? You want me to put my magnet where I am right now? And it's like, shows context, right? Shows time, dependency, and context. And the other thing that they would do is they would argue with each other. You can't put your magnet there. What?
Remember, sir, this mic. Sure, an event ID maybe. There's no password on the meeting, so if you want to close it and reopen it, and I can give you the event ID. Okay, it's 748-694-946. Yep, we're currently having an issue on this end, so we're rebooting the computer and they'll be out shortly in terms of the audio and video. Yep, no problem. Bye. Morning, Counselor, this mic. Okay, yep, we're working on it. Yep, bye-bye.
And now I want you to move to the second continuum and the same sorts of questions. What factors did you take into account when you placed yourself on the gender expression continuum? Did you think about your personality, your clothing, your hairstyle, your interests, your appearance, how other people perceive you? What led you to kind of put yourself where? Why did you place yourself where you did and not on the point either side of where you did? And the last question is your gender expression congruent with your gender identity? Why or why not? Okay, and now I'd just like you to locate the person or where you all placed yourselves. Still not working. It won't forward it. Okay. Mm-hmm. Mm-hmm. Okay, and then, woohoo! Woohoo! If your mouth is closed, raise your hand. If your mouth is closed, raise your hand. Good. Oh, good. We got good. Thank you. Do you teach kindergartners? That's good. If your mouth is closed, good. Okay, we need to kind of move quickly. This is just to give you an idea. Lastly, with your neighbor, discuss what it was like to learn about yourself in terms of these continuums. What did you learn about yourself? We're just going to do a few minutes, so if somebody didn't get to go, maybe have them go first now. Go for it. 2 minutes. Okay. If your mouth is closed, raise your hand. Mouth is closed, raise your hand. Good, good, thank you. So I'm sure that could move into discussions at lunch, right? Lots to discuss there. What I want to do is give you insight into how our adolescents did that activity. So this is a picture of how our adolescents did that activity. Each colored shape And I should say that we had both the parents and the adolescents do that, but that would get really complicated if I tried to depict that. So this is just the adolescents, which is complicated enough. So each colored shape represents a particular youth. So the red square is JM. See JM. Oh, now the pointer. Oh, man, I hope I don't screw something up. No, I don't know. You see JM in the top over there, and then their squiggly line kind of goes right to the middle. Okay. And you can see that WD is way up at the top there, and then way down at the bottom here. WD just refused to do the activity. They said, these spectrums do not encompass me. I am 3D, and I cannot do it, and tried to stage a coup in the group to have everybody refuse to do the activity. The top left corner, SG, the pink one, also did not like the labels. So that person said, I'll stand here, but really I'm polygender or big gender. And on the bottom, if you look at their curvy line, they labeled themselves as queer. Top left corner, JM, quickly placed themselves on the identity spectrum. And we also do this on a duct tape on the floor, and then they go and stand where they are. So WD just made a beeline on the gender identity thing. Very clear about that. Quickly placed themselves on the identity spectrum, but then took a really long time to figure out where they wanted to place themselves on the expression continuum, finally deciding to kind of move into the middle. And so we kind of asked JM about that. That took a long time. What was that about? And what JM said was, I'm conflicted about cultural norms related to masculinity. I don't know if that fits with anybody in the room. If you look at the bottom one that's blue, that's RH, and DK, which is the rainbow colored one, these show the struggle of how they see themselves versus how other people see them. So RH said, I'm perceived here on the gender expression, but I really want to be here, more towards the masculine side. Whereas DK knows that they're perceived as more masculine, but they'd like to be perceived more in line with their identity. So a lot of the struggles that the youth have is how is my expression being perceived versus how I'm trying to give my expression off. And that's a huge struggle for some of our youth. And then lastly, TD, who's on the bottom right, shares how she has handled that internal struggle brought on by the pressure in society to be more feminine. So does everybody see where TD is? No? TD is the star, and her gender identity is very, she's kind of very binary in terms of feeling like a female. And then she placed herself here. And what she said was, let me quote it. I used to think that I had to be more to the right. I used to think that I had to be more feminine. But what I really like to do is I like to be here. And so they're really understanding, they're kind of gender literate in terms of they understand the cultural pressure is if you identify as a woman, gender identity, then get in line and get your expression in line with what people think women are supposed to do. And I think trans people get that doubly. Get in the box that you're trying to tell us that you think that you are, because if you don't, it's just really confusing for all of us cisgender people. So from this activity, the adolescents and parents learn that while there are lots of messages that are asserting a binary view of gender, they learn one thing, that it's okay to be binary, it's okay to land on the ends, and it's also okay to move beyond the binary and land anywhere on either spectrum, and that it's also okay for your gender identity and your gender expression to be congruent or not to be congruent. And these are then discussions that they bring home. I really believe that the whole therapeutic points that happen in the group is that happen on the drive to group and the drive home from group. That's when they really probably do the most of their processing. So so that's the Tumblr stuff, if you want to go on Tumblr. So health disparities in trans youth. It's a fact that trans youth have huge health disparities. In 2015, Reisner published a retrospective study of 180 charts of transgender identified youth and found significantly higher rates of depression, anxiety, suicidality, self-harm behaviors, all than cisgender youth. There was also more concerns of kind of body image, substance use, post-traumatic stress, and sexual risk-taking behaviors. So we have a big problem that is largely probably based on that Olson study due to stigma and discrimination and how that impacts people's mental health. We also know from the research, it's very clear, that various kinds of support are very significant protective factors for youth. And this is not news to people who work with youth. Having a supportive family is golden. What's fascinating is the difference in the range of how the youth versus the parents perceive their level of support. So just by the fact that they're coming to our youth group and the parents and the youth are coming together, kind of puts them in a pretty high kind of level of support. But it's really interesting to see how they rate their parents' level of support and how their parents rate how supportive they are. So there's some studies that need to be done there. Also, attending a culturally sensitive, open-minded school, or finding those pockets of acceptance. So Children's Theater Company, you know, things that have very inclusive environments is very important, a protective factor. Friends who get it, protective factor. And I think we have a lot of concern about how much is happening online, how much peers are interacting online. I think that's a valid concern. And I can tell you that trans youth have a ton of support online that if we can tap into it positively is really good. And then there's also some of the negative things that can happen. But I think we need to acknowledge that there is really positive stuff that can happen for trans youth specifically online because they're exposed to a broader spectrum. And then there's peer support groups like Transforming Families. And then there's supportive therapy. So all of those things can be protective factors. And I did a talk with a public health nurse at the World Professional Association for Transgender Health in Amsterdam. And she did this really interesting frame where she kind of said that this is a public health issue. She framed it as a public health issue, that we need to be thinking about this in that way. So just to give you some basics about adolescence, social transition can include changing name, whether it's done legally or just kind of in practice, changing preferred pronouns, including use of gender-neutral pronouns, coming out as trans to friends, family, at school, living partially or fully as their experienced gender, and then actually changing legal documents and gender markers and kind of all that stuff. And there's been a ton of evolution on that. When we first started our group, we would have Phil Duran, who's a lawyer for Outfront Minnesota, a LGBT advocacy organization in Minnesota, come in and do like a little in-service on legal stuff related to trans stuff in our youth group. And at that point, there was this huge procedure for how somebody could change their gender marker on their driver's license. Now, 5 to 7 years later, a youth who is identifying as trans can get their driver's license in their experienced gender. And that's because people like Phil Duran are doing that kind of legal stuff. Medical transition can include, because again, the narrative is once you get on the trans train, you go all the way, right? But that's actually not what happens. And that's not what we should be promoting. We should be promoting what's going to feel best for you and what interventions are going to work best, and how do we help you with that. So medical intervention can include masculinizing or feminizing hormone therapy, gender-confirming surgeries, and per the empirical research, when the standards of care are followed for adolescents, things are pretty successful. Adolescents that followed the standards of care through some medical interventions had no regret and demonstrated psychological well-being in the normal range, which means the cisgendered range. That's why it's in quotes, well into their 20s. And then it's important to just know that not all trans adolescents or adults choose medical intervention or social transition changes, and that only about 20% of trans adults actually choose or are able to have surgery. So that's kind of the popular narrative, that that's the thing that everybody's going for, but that's actually not always what's important. And there's also so many barriers to having that happen that even if somebody wants that, having it happen is pretty difficult. And with the Trump administration will probably get harder. So for some of the most up-to-date information, the World Professional Association of Transgender Health publishes standards of care, and this provides a collection of the strongest empirical evidence on transgender health care. And based on that, it offers best practices for, and so there is best practices standards, but they say very little. The latest version, version 7, was published in 2011, and in terms of adult care, it made tons of changes. I mean, it really responded to the research that we now know about and kind of the cultural landscape changing, and made huge changes. Because there wasn't, at the time of that publication, because there wasn't that much research being done yet on adolescents, that version looks really similar to the previous version, but the newest version will come out, and I bet that's going to have some pretty significant changes, largely about the timing of medical interventions for adolescents. And when you start to talk about medical interventions for adolescents, one of the things that we have to be aware of is fertility. And unfortunately, fertility isn't getting talked about as much as it should be getting talked about in terms of informed consent. So we can talk about that a little bit in a little bit. So these are the medical interventions for adolescents. Let's start with puberty suppression. Puberty suppression is considered to be a fully reversible intervention. That is in quotes because that's the way it was conceived, and that's the way it used to be used. But given that it's now being used in some ways as kind of the first step of a medical transition, that everybody's going to do this and then they're going to do that, it's no longer kind of as fully reversible as we used to think that it was. Okay? The original intent was just to push the pause button to allow for more exploration. If there was going to be a medical transition in the future, if you're on puberty suppression, it's likely that you'll need less medical intervention, there'll be less cost, and the youth will have developed less of the secondary sex characteristics that make it hard for them to function in the role that they would like to be in. But like I said, the concern now, my concern, is that suppression is being seen more as just the first step of a medical transition. And in essence, this means that decisions that we thought were going to be made about fertility that happen when you start doing feminizing and masculinizing hormones, right, around 15, 16, puberty suppression happens right when the kid starts to enter puberty. So now we've moved those decisions back to even younger, because once you go on puberty suppression, what's happening? You're not going through the process of puberty that allows you to get to the point where you're fertile, right? That's not happening. You're suppressing that. And then if you add feminizing or masculinizing hormones on top of that, which is the standard of care, and that makes sense, then this person has never developed the capacity for fertility. So they then are making decisions about their fertility when you start puberty suppression, if you see it as the train's going. Now, if you don't see it that way, if you see it as we are really going to push the pause button, then what would need to happen for a youth to keep their fertility preservation is they would have to go off the puberty suppression for long enough to develop the capacity to have fertility, which means they're going to have the effects that they didn't want to have in the first place that led them to be on puberty suppression. Does that make sense? And then you get the capacity for fertility. You then harvest eggs or store sperm, and then you go on masculinizing or feminizing hormones. So it's very tricky, and it's very important, and you bet that youth are saying, I don't care about fertility. Because who does? Right? It's kind of like not something that is developmentally on the radar, nor should it be in adolescence, and yet the decisions that are being made are decisions that will affect fertility long term. So that's why I think this is really important. And I did a talk for the Reproductive Health Conference, and that's where I researched all of this stuff. And I realized, oh my gosh, we have not been doing a good job talking about this with our clients. We have not been doing a good job with informed consent because fertility, I looked at all the research articles, there was one chapter, there was 4 paragraphs in one chapter of one book that talked about teens and fertility implications from medical interventions. That's kind of where the field is at, which is why I really just want to put it out there that this is something that we need to do more thinking about. Okay? So puberty suppression, the other thing is that youth must feel supported to change their mind. So it's that same thing as the early social transition. Puberty suppression is really costly. Even if you get insurance to cover it, it's still pretty costly, and it involves a lot of medical appointments. It's a commitment. And so for youth who decide that they want to go off puberty suppression, you have to have an environment where it is okay for that to happen. Because a lot of youth are like, wow, my parents went through a lot to have me be able to start Lupron. My little brother isn't able to go to gymnastics anymore because the cost of Lupron is too much, and the family made that decision, right? And now I'm just going to kind of say, oh, you know what, I think. So we have to be in a position where we can support them to change that. You also are not supposed to prescribe the standards of care. There's controversy about this. The standards of care are that you don't prescribe any earlier than Tanner stage 2 or 3, which is an endocrinology term, but it basically means that the youth has gone into just enough puberty that it's breast buds and an increase in testicular size. And I don't think people know when they have breast buds. People don't really aren't usually checking their testicles. Youth usually aren't, I don't think, but that's the signs for it. And if you have increased testicular size and breast buds, then other things in puberty are happening enough that the youth can begin to see, what do I think about this body that's becoming? But there's not enough development that you can't, if you pause it right there, that you won't be able to kind of present and be in the role and not have to have a bunch of medical interventions later on. So that's kind of the thinking around that. So it involves a pediatric endocrinologist because there's lots of medical stuff that's involved in this. The cost is huge. I've talked about that. And then the other thing is that there's little hard data so far on the impact of Lupron. We talked about the case for precocious puberty. So people say, well, we've been using this medication for years in precocious puberty. It's the standard of care. What's the big deal? Well, the big deal is that when a kid is going through precocious puberty, they're not supposed to be going through puberty. When a kid is supposed to be going through puberty, besides the secondary sex characteristics that the youth is so concerned about if they're gender dysphoric, there's also a lot of other stuff that's important about puberty. And so if we're suppressing that, those important processes, what's the impact? And we're just starting to kind of look at impact on bone health, impact on brain development and myelinization, and then, of course, we already talked about the impact on fertility. So for They would prescribe it on a medical basis because the youth has gender dysphoria, and this is the way to push the pause button on the body that they don't want to have. Right. Okay, so that's about puberty suppression. There's lots to learn about that. That's another 3-hour conversation, but I just want you to know that it's on your radar. And then hormones are partially reversible. There's no longer an age requirement in the standards of care. It used to be 16, and all of the research that's been done, those youth that have done really well in the protocols, were all done with hormones starting at 16. So we don't really know what the outcome's going to be for youth who are starting it at 15 or 14, but it's likely that the standards of care are going to decrease that age, the age limit, and it's much more common now for youth to be starting hormones at 15 and maybe even late 14, because there's the argument, and it's a good argument, is that that's when the rest of their peers are going through puberty, and why are we limiting that? The con would be, you know, can a youth really make that informed consent decision? The other thing that's important to know is that different regimens are needed for adolescents. So if you're really good with adult transgender hormone therapy, that doesn't mean that you know how to do adolescent hormone therapy. It requires even specialized knowledge. So the other point about this is the earlier the youth starts puberty suppression, the earlier they're going to need to probably start hormones, because what hormones do is they put back into the system all those things that the body needs that are happening in puberty for bone health and that kind of stuff. So as the timelines go down, the timelines go down. And it's just an important thing to be aware of, that there's lots of controversy about this right now. So I know that Dr. Feldman is going to talk more about this medical stuff, so we're just going to kind of zip through this. These are the feminization effects. These are the masculinization effects. This is Nicole and Jonas. These teens were identical twins at birth, both assigned male, and they demonstrate the impact that puberty suppression and hormones can have. Surgeries for adolescents and adults, they are irreversible, obvious, you know, well, I mean, you could get breast augmentation, I don't know. They're irreversible. The legal age of majority to give consent for medical procedures in a given country is what the standards of care would say. So in the US, that's 18. Chest surgery for masculine spectrum youth can be done before the age of 18, preferably after ample time of living in the desired gender role, and after they've been, if it's applicable, because some teens want chest surgery but don't want to take T, and that used to be unheard of. You know, if you're going to do this, you're going to do all of it. But now we know that that can be that can be something that can happen. And so if applicable, if someone wants to have chest surgery, the standards of care are that you'll be on 1 year of T. T is testosterone. It's the hormone that masculinizes, okay? So this slide is just basically that trans adults, they've done studies on trans adults, and trans adults do say that fertility is important to them. They do say that parenting and wanting to have their own kind of biological children is important to them, and that regardless of whether that was important to them at the times that these decisions were made, the majority of trans people really expressed that fertility preservation techniques need to be discussed and offered, and that for many of them that wasn't the case, and so we need to be doing a better job at that. So that's kind of what we know about fertility in adulthood for trans people, yet in the 100 or so teenagers and young adults that I have worked with, 1 has decided to harvest their eggs, and 2 have decided to store their sperm. And remember that these options aren't even viable for youth who've been on suppression.
Is that number so low in terms of harvesting eggs and because of the cost involved?
So the question, yes, the question is the number low because of the cost involved? I'm sure that's part of the factor, but I think the bigger part is that the discussions haven't been had. Now, once you have the discussion, then people go out and do the research. And yes, the harvesting of the eggs is hugely complicated and, you know, very intense. Storing sperm isn't that big of a deal, although it is a big deal if you have gender dysphoria. So I think the point of this is just to say that I don't think even at our clinic we've been doing a very good job with having these discussions. And that's what I mean by informed consent. Knowledge is power, and in order to give informed consent, we have to really be talking about this stuff lots of times across disciplines. So the physician needs to talk about it, I need to talk about it, the parents need to talk about it with their youth, and that we should be having that discussion each time there's a medical intervention. You don't just have it for one session and then that's good for the rest of the time, because their minds are growing and changing and we're learning things and all of that. And so it needs to be a process over time. Okay, we are going to take a break, a 10-minute break. So come back here at 5 to 11, and we're going to start at 5 to 11 to do the adult. If you have questions, come up and talk to me at the break. Oh, and I have pronoun buttons. If you want a pronoun button, come on up. Yeah. We're gonna get started. I said 5 to 11, and there's nothing like having clear boundaries, right? Okay, we're gonna get back started. And we're gonna switch our focus to adults now. And I'm going to do the adult focus and weave it in with this gender affirmative lifespan approach that Katie and I are kind of playing with and trying to figure out. So our approach, the gender affirmative lifespan approach, is based in the theory and clear research that shows that stigma and discrimination and lack of access to care contribute to negative physical and mental health outcomes for trans-identified and gender-creative people. It is very clear. Stigma and discrimination and lack of access to care contribute to medical and mental health outcomes that are negative. So we did health disparities in trans youth. Let's just look at the health disparities in trans adults. The National Transgender Discrimination Survey of 2011 was a survey of over 6,400, so huge sample, of transgender adults from all over the United States. These are selected findings from just the health section. In addition to the rates of HIV infection being 4 times higher than the general population, there are also much higher rates of smoking, drug and alcohol use, mental health concerns, and suicide attempts compared to the general population. Transgender people in this survey reported having to teach their providers about their care. This is not surprising, as both undergraduate and graduate medical education on transgender-specific care is lacking in most medical schools and residencies. What's really cool is because the program in human sexuality exists at the University of Minnesota, our residents and medical students actually get some education about this. Because of this lack of knowledge, health providers are ill-prepared to provide gender-related health. And often transgender people who are seeking primary care, they are coming in for a cold, get told, we don't see your kind. We know that transgender adults tend to postpone care due to discrimination. And lastly, nearly 1/5 of respondents in this survey had been refused medical care. So statements like, hey, we don't take care of that, or we don't see that here. So what these statistics look like in real life, if y'all want, this would be the one time where it's okay to take out your phones and type in #transhealthfail and see what comes up. What's happened is because of all of the disparities and the discrimination in the healthcare system, transgender folks created the #transhealthfail, and people are posting what their experiences are. So one of the experiences that's here is there was a time I had to get a pregnancy test before getting a chest x-ray despite lacking a uterus. #transhealthfail. Some other ones are, I know you can't read these, it's just to demonstrate that it's real, I'm not making it up. Nurse, when was your last period? Patient, never, I'm transgender. You really fooled me, I thought you were a woman. #transhealthfail. And just to think that this is only about medical doctors and psychologists are like exempt in some way. I'm a specialist psychologist I had a specialist psychologist when I was doing an ADHD assessment who asked about my surgical status. Remember the cisgender green thing where I said, don't ask people about their surgical status. There's nothing in an ADHD assessment that would require somebody to know about your surgical status. Nobody that did a cisgender ADHD assessment would say, by the way, what genitals do you have? I just need to record that right here. Okay? So in response to this, we've come up with this transgender, or this gender affirmative lifespan approach. And there's a philosophical underpinning to this, and then there's kind of the interventions. And so whether you're a school teacher or a public health or a psychologist, we think that there's applicability across this to a lot of different disciplines, although we see it as a psychological thing. So first of all, we're trans affirmative. We believe that transgender is an identity, that it's not a disorder. And it's central to our approach that trans identities, just like cis identities, are a normal part of the spectrum of gender experience. Our job is to support clients in making the best, most informed decisions for themselves about their gender identity, not to decide if they are trans or not. The clinical issue is that some people who identify as trans also have dysphoria, which can include both anatomical dysphoria, their body doesn't line up with how they feel about themselves, or social role dysphoria. And there's a lot of individual differences about how extreme that is. According to the World Professional Association for Transgender Health, standards of care, psychotherapy that's supportive in nature, hormone therapy, and surgical interventions are all medically necessary interventions to address gender dysphoria. If a trans-identified person is diagnosed with dysphoria, treatment, maybe psychological and or medical, can help that dysphoria to lessen and even go away to the point where the person no longer meets the diagnostic criteria. We also believe that it's really, this is why I did the developmental thing that I did today, talking about children as separate from adolescents, as separate from adults. So we also believe that it's really important to have a developmental perspective. What I want to call your attention to is not understanding this whole chart. That would be ridiculous. It's about noticing that in the vertical row represents kind of lifespan stuff. You've got children, adolescents, young adults, adults, and older adults. So note that adulthood actually encompasses 3 rows on the grid. This is to remind us about how quickly things are moving in trans healthcare. The experiences of our older adults are very different than those of our younger adults. The toll of hiding in an inauthentic life that is shame-based due to stigma for 40 to 50 years has a very different impact than growing up with the language, the pockets of support, and the range of options that are available and that were available 10 to 15 years ago. So we did this really at our clinic. You know, we've got all ages coming, and so it's really fascinating when a trans adult sees a kid in the waiting room. They come in and they're just like, I can't believe. There's both. I can't believe that the kid is getting the support that they need. That's so great. And there's also this bittersweetness of, why couldn't that have existed for me? And so there's a lot of grief around that. The other thing that happens is one time, just by kind of, we moved one of our groups to a different time. And so it just happened that the youth group was in the waiting room waiting for their group to start at the same time that an adult transgender group happened to be in the waiting room waiting for their group to start. And we found out later that both of those groups spent the whole group, just abandoned what they were going to do, talking about what it was like to see both of those age groups and what that meant to them and how important that was to them. And so there's these huge generational differences. So you can't just have adults be adults. You've got to think about them as having their own kind of age range. Because there's varying levels of need and intervention, You know, we know that for children, we know that for adolescents, but even in adulthood, there's varying levels of need for intervention depending on what their experiences have been. So young adults are a lot more non-binary. And a lot of their issues, just like regular young, or, you know, look at what I just did. That you have to catch yourself on. Just like cisgender adults have individuation as a developmental process in young adulthood, so do trans adults. And so, but navigating college as a trans young adult, an early career, do I tell people, do I not? Who am I going to room with? Is the college on the 10 list of gender supportive things? How do I talk to my dean of students about this? All of that stuff is very different than what an elderly adult is facing. The influence of social media has been huge. And then starting relationships. A lot of our older adults went into relationships either not knowing that there was a gender component, or maybe knowing but thinking that they could manage it and it wouldn't have to involve transition, or just denying it totally, and then now you're in this position where you do want to lead a more authentic life, and you've been in a marriage for 25 years, and you have 3 kids. That's very different than the young adult who's just starting relationships and can make those decisions about how much do I disclose, when do I disclose, when in the dating process do I do that? And then do I want to live my life in more of a stealth way or in more of a non-stealth way? Depending on the level of medical intervention that's been available to people, they have that option now. Elderly trans adults do not have that option. They did not have the medical intervention that allow them to not be read or clocked or whatever the terminology is. And that's a huge difference in how you think about and provide care. So those are some of the kind of generational differences that are important. And just to mention older adults, so we run groups that span the adulthood, and I've got people in my group that are like 70, and I've got people in my group that are like 30. And then there's a young adult group, and then there's our adolescent groups. And a lot of the 70-year-old issues are also about what's this going to mean? What is it going to mean to be trans and go into a nursing home? Is my identity going to be supported? Is there a community for me? Because they're much less likely to exist than for our young adults. So there's some specific elderly trans issues that we need to have kind of on our radar. We also think that there's a really importance of intersexuality. Transphobia exists. Stigma and discrimination is a part of trans people's lived experience. And so people exist within multiple identities and multiple systems, and all of that intersects to cause people's experiences. I recently did a 2-day training at an Army base in Seattle as they're getting ready to have trans service members be able to be out in the military. And we talked about what is the role that the military culture plays in your trans service members' experiences. You can't address one aspect of identity without impacting the others. Philosophy-wise, we think that you have to have an interdisciplinary approach. It takes a village to do competent trans health care. You can't be a little satellite. And then we believe really strongly in transparency, and this is something that Katie, my colleague, has really done a great job with in our program. Transparency goes a long way in forging a new framework for the role that mental health can play in trans care. Historically, psychologists and mental health providers have been put in a position to be a barrier to medical intervention. So in some ways, we kind of got thrown under the bus. We became gatekeepers to services that people wanted to have. That's changed now. That's no longer like that, but it hasn't changed in the consciousness of the community that had that historical negativity practiced on them. And so it's very common for people who have that historical narrative to come in and be very suspicious that you're A, not going to be supportive, and B, you're just going to get in the way of what they want to do. And so I think it's really important that as a transparency move, we be really upfront about understanding that historical negativity, asking about that historical negativity, and being upfront about what you believe the role of therapy is in terms of trans healthcare now. We also have to be really transparent within ourselves, which is partly why I did that exercise where I had you guys label yourselves on the continuum. We have to be aware of our biases and assumptions about what it means to be trans. We have to have an understanding of our own gender journey, that we all took one. We just might not have been as obvious about it. And if you happen to be L, G, or B, then you might have had your own coming out journey that was filled with maybe your own sense of stigma and discrimination and celebration. And it's really important to, while we can draw on that in some ways, we also have to recognize that the T is different, and the LGB experience is not a catch-all for understanding the trans experience. And so there has to be kind of transparency within ourselves to really look at that. So we're going to talk about the kind of the interventions. So I've talked a little bit about this already. Gender literacy. So each of these are going to have a circle. You can see that around the outside is the lifespan, and then within each are just different kind of interventions. So obviously we can't talk about all of them. That's a 3-day kind of workshop. But I just want to explain the general concepts. Gender literacy is about the process of learning. This is what we think gender literacy is. And I think we might be coining the term. So if you use this term, you should kind of coin us. It's about the process of learning to identify and name oppressive practices within society as they take shape within the lives of transgender and gender diverse people. So gender literacy is about understanding what the different aspects of one's sexual identity are, so the genderbread person, and how they uniquely come together in each person. And in developing this, people begin to understand and get literate around the fact that our bodies don't have to define our gender identity or our expression. For some people they do, and that's great, but not for everybody. That's why continuums are wonderful. With children, we do a lot of interventions designed to process their awareness of the unwritten rules, kind of use rules because kids are real rule-based, that are projected. There's lots of rules that are projected by the gender binary, but they're fake rules. They're not real rules, they're fake. And those rules impact children. For instance, we use the Roland Humphrey book that's in that, you saw Roland earlier. In that book, the children in the book are working really hard. Does anybody know that book? Oh, get it. It's so wonderful. The children in that book, who are Roland's friends, they really are Roland's friends, are working really hard to get Roland to understand and adhere to the rules in order to be a real boy, because they know that Roland's going to catch some crap if Roland doesn't do that. So a child who's developing gender literacy is not only able to have a working knowledge of what those rules are, but is aware of what can happen if they don't adhere to them. And then they're able to externalize rather than internalize those rules. And by doing so, they're able to form their own ideas about the extent to which they want to follow or not follow those rules, and the extent to which they allow those rules to dictate how they think and feel about themselves. So that's a big job. And it's not something you do in 1 or 3 or 7 sessions. It's an ongoing process for the kids that we work with. But we think it's really important. I think, research might prove me wrong, I think that that is a building block for a protective factor. We also do a lot of stuff beyond the binary. So we've already talked a lot about this. We believe that normative gender and sexual binaries pathologize nonconformity and limit the range of full expression. And so we really want to move beyond the binary. And we want to have an approach that is inclusive and affirmative of a range of gender identities. And so that activity that we did with yourselves and that we do with the youth is a great activity to do with clients, because it just kind of puts it out there. We're not buying into this binary stuff. We want to go beyond the binary. Resiliency. So I think somebody asked about kind of survival skills. Resiliency is a key component of what we think supportive therapy should involve in terms of gender health. Building resiliency involves learning how to overcome adversity and effectively cope with stressful and challenging situations in life. So it's really good for everybody to learn how to be resilient, right? That's what we want for our children. But if you are somebody who's facing a lot of messages that are saying there's something wrong with you because you don't adhere to these rules, then we really need to kind of buff up that resiliency. So resiliency building, we think, kind of involves two things: having safe spaces, so having family, friends, community groups that you feel safe in to share these difficulties and gain support. And then the other skill that it involves is really being able to kind of stand up and stand your ground and be who you are and know what contexts it's safe to do that in. Let's see. Elderly trans adults are particularly isolated. And so as we talked about earlier, due to generational differences, their experiences related to gender have been very different than adults who are a bit younger. So one of the things that we're working on doing is trying to have an elderly, like people, and it's funny because Katie's not as old as I am, and so she kind of had the age range. It's getting lower as she gets older about what is an elderly adult. But we want to have a group that's kind of for 65 and over and see kind of what that discussion leads to. Another core component of the gender affirmative lifespan approach is positive sexuality. And that's because we're at the program in human sexuality, and we think this is great across the board. Research and practice in the past have largely focused on the negative sexual outcomes for transgender and gender diverse people. So there's lots of information about STIs, including HIV risk, out there pertaining to transgender people, but there's very little information that's age appropriate about how trans people deserve to and can experience pleasure-based sexual satisfaction. So one of the projects that we've been working on developing is a sexual health website specifically for trans adolescents. So we did focus groups, and we said, hey, if we could build a sexual website that was what you wanted, what would it look like? And we're now kind of going through the transcripts of that to try to figure out what do trans youth need that would actually be appropriate, because what we know is there's tons of websites that they're getting that maybe isn't the information that we want them to have. We need to build something that is the information that we want them to have. And then Katie, my colleague, has recently read a chapter in a sex therapy textbook that outlines sex-positive sex therapy interventions for trans adults. And she's working on developing a curriculum for trans women to get in touch with either pre or post-surgery, kind of their bodies, and what can you do with the body that you have, and if you end up able to have surgery, how is your sexuality changed, and how can you move into a pleasure-based kind of way of thinking about your body when for so many years you were kind of trying to avoid or not have anything to do with your body, because sexuality is inherent in our bodies. So it's a really important piece that we need to have in our model. And then the last part of the model is connections to medical interventions. Connecting our clients to medical interventions and doing this is a really crucial role that we fulfill. If you're going to be a gender specialist, you have to know and be able to kind of write the referral letters and be able to intersect with medical providers around medical interventions. And I think the fertility stuff that we're working on is kind of cutting edge in terms of that, because even in the trans community, it's not really being talked about. So how do we broaden fertility options for trans-identified people? So back to kind of this model. So looking at the different components that go across the top and the age span, you can start to see that there's lots of interventions that can kind of fit within the different grid. But what I want you to get a sense of is that all of these, we believe that all of these core components are important, even though they might look different and you might interface with them differently. They're all important across the lifespan. So positive sexuality for our kids, the top one with that cute little picture, some of it's just giving images that match how their bodies work. So you have a kid who has a gender expression that would be considered feminine with a penis. And kids aren't seeing those images. So that's promoting the sense that your body's okay. Your body's going to do cool things, right? And then all the way down to what I just talked about in terms of Katie doing kind of reparative work with our trans adults on how do you embrace your sexuality and have a satisfying sex life as a trans person. So that's kind of our model. Again, that's another 3-hour talk, but I just wanted to put it out there. Last thing we're going to do, revolutionary actions. So let's end by having all of you think about some revolutionary actions that you can do personally or professionally to help this revolution of the gender climate. So I want you to talk with your neighbor now about 3 actions you can take in your personal life and 3 actions you can take in your professional life to change the gender climate. And then talk a little bit about what barriers or challenges might come up. And how are you going to have resiliency? How are you going to persevere as you try to do this revolution? Okay, so go ahead with your neighbor and come up with 3 personal things and 3 professional things. Okay. If your mouth is closed, raise your hand. When your mouth is closed, raise your hand. So, thank you very much. So we could spend a ton of time doing this, right? Which is what's so awesome. We can make change. And I would suggest that if the people that run your organization are open to it, that you email all your ideas to them. And they can, the professional ones, and they can maybe start to kind of think about what you all were thinking. But what I want to do is just kind of come up with, maybe some of these are the ones that you all came up with, but these are just some ideas that have come up in past trainings, just to kind of give you a sense. Wearing a pronoun button when you are out and about. There's nothing like having a pronoun button on that doesn't signal, I am in the know and I want to do this work. Asking everyone to say their pronouns. Yes. Yeah, I would just Google pronoun buttons, and I bet it'll come up. You know, just Google. If you really are, if you're not successful, I can ask my people where they got them, so you can just email me. But I'm sure that's what Ethan did. Asking everyone to say their pronouns at a staff meeting. That's actually a really cool intervention. Standing up for people who get misgendered. Reading a biography of a trans person. Donating to the Minnesota Transgender Health Coalition. Inviting your family to watch a show on trans lives. Tonight at dinner with your family, if you have a family or whoever you're out doing stuff with, just try to say, you know what, y'all, for the next hour, none of us are going to use binary pronouns. We're going to do an experiment. We're going to see how long we can last before we screw up and have pronouns, because language is really important. So just as an experiment. Create gender-neutral restrooms at your work site. Talk to someone about cisgender privilege. Write your representative or senator about transgender legislation. Shop at Target. They have a pro stance. Advocate for changes to your electronic medical records so that people can be identified in there the way that fits best with them. And that is a hard ball of wax to solve, just so you know. Advocate for inclusive health care coverage at your workplace. At the University of Minnesota, this is hilarious, this is awful. At the University of Minnesota, if you are an employee of the University of Minnesota, at least in the last couple of years, you could not, the insurance that the University of Minnesota had was not inclusive of gender-related care. Right? So the people who worked at the program in human sexuality, who wanted to access gender-related care, were excluded from doing that. I think maybe that's changed now, but I mean, that's kind of the craziness. And then you can donate to the program in human sexuality. Let's finish with a few questions, and then we'll end with our last slide. Yeah. Yeah. Great. Mm-hmm. Yep. Is doing. Yep. You go, sister. You go. Yeah. Oh, everybody's going to say their actions. I love it. Yep. Yep. So what's your revolutionary action the next time you fill out a form? Or you could even. Or add other, or tell them. Yep. 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 Everybody freaks out. Yep. Good. Yes. Yeah. Mhm. Right. Mhm. Yep. Right. No, it's a great point. And also, different cultures have different rules, and so how do we be sensitive to that at the same time that we're trying? That's that intersectionality piece. Yep. One last comment. Yeah.
Making sure that everyone in the office is familiar with the importance of pronouns and names. I had my office manager make a note
Yep.
for my trans patients of what their preferred gender, name, and pronoun
Yep.
is, so that when they come in, she could be
Yep.
supportive of that and making sure that that was really known.
Yeah, and I know that Dr. Feldman this afternoon, because I've looked at her slides, is going to do how do you create a welcoming environment of care, and that's a huge piece of it. Training our front desk staff, because that's the first people that see. Having our waiting rooms have Roland Humphrey books in the waiting room. You know, those kinds of things are really important, because for cisgender people, it's just going to go over their heads. But for gender creative children and trans people, they are going to notice. You bet that they will notice. Great, so you all can do your revolutionary actions over lunch, all right? My hope is that someday soon, with all of us more awake, and even with the threat of a few dead ends, that TG Healthcare will improve enough to bring about a new hashtag called #TransHealthSuccess. That's my hope. Thanks for having me. I hope you have a great lunch and a great rest of your day.